Hi, everyone. Thanks for joining us. Welcome to Post-Hoc Live. My name's Lydia Ramsey Flanzer, and I'm a deputy editor here at Endpoints overseeing our health tech coverage. We put out a twice weekly newsletter, so be sure to subscribe if you haven't already. If you're joining us for the first time, hello. Post-Hoc Live brings reporting, analysis, and debate that usually happens behind the scenes in our newsroom live to you. If you're joining us on YouTube and you're not already following us, please hit the subscribe button below our feed to get alerts about future live streams. You can also sign up for the post-hoc email on your Endpoints News subscription page. The health tech team is taking over Post-Hoc Live today to talk about why exactly it's so hard to tell how well digital health tools work. There are a lot of digital health tools on the market to do things like manage diabetes, depression, high blood pressure, any number of other medical conditions. The companies behind these tools often make big claims, but they don't actually have to prove their claims before they get patients and companies to sign up for it. This sometimes really confuses my biotech colleagues who are very used to the rigorous clinical FDA process. And so that's where Caroline Pearson steps in. Caroline is the executive director of the Peterson Health Technology Institute, which evaluates all these digital health tools to figure out how well they work and whether they're actually worth the cost. The Institute came out with a new report today on virtual opioid use disorder solutions. So today she's joining me and health tech reporter Nai Young to talk about the report and the Institute's work overall. For those of you joining us on YouTube today, you can use the live chat to join the conversation and ask questions. If you miss us live, recordings will be up on YouTube and Spotify. Caroline, welcome to Post Hoc Live.
I am so glad to be here. Thanks for having me.
Yeah, of course. So I wanted to start by talking a little bit about the Peterson Health Technology Institute for folks who might not be familiar. What's your remit there and how did it get its start?
Absolutely. So we launched in 2023, and we were a major initiative of the Peterson Center on Healthcare, which is a philanthropy focused on improving healthcare affordability and outcomes in the United States. And we understood that we spend a ton on healthcare, and unfortunately, we get too little in return. We have poor clinical outcomes. We have lower, higher mortality rates and lower life expectancy than other comparable countries. And so we always believed that technology had a really important role to play in achieving our health aims, in closing access gaps, in driving better actual health, and in lowering spending to a rate that's going to be more sustainable as the country ages. And so we were interested in sort of how we could help as a foundation. And we started talking to people in 2021 after the COVID pandemic had reached its peak. And we heard over and over the same thing from health plans, from employers, and from health systems, which said, we have adopted a lot of health technology very quickly during COVID, and that was great. It was catching up from, long overdue shift to being technology enabled. But they said, look, we're overwhelmed. We've got digital health companies knocking on our door every day. They've got wild claims about what they're going to do for us. But we really don't know if any of this works. We know we're spending a lot of money. We don't know if it's reducing costs long term, and we're struggling. So we said, this is an opportunity for us to help. There's an information gap across lots of different actors in this market, and it's potentially something that we can fill.
Got it. Yeah. No, it was one of those things. Now I might remember this, but the minute I think it was the diabetes digital solutions report hit, I was like, okay, where has this been for the past 10 years of my life covering health tech? It's always hard to know exactly what you're looking at. So it's interesting to see this kind of pop up. So when you put out these reports, it's not always something companies want to hear. It seems like a mixed bag sometimes. Sometimes people love it, sometimes people hate it. What kind of reaction have you gotten in the past year and a half of putting out these reports, and has that changed since you got started?
Yeah, well, I think first, let me kind of tell you how we do our process, because I think it matters a lot to people in terms of what you see on the other end. So as you teed up at the beginning, digital health tools, most of these don't go through the FDA. You don't have the same level of clinical rigor. And so our reports really seek to answer two big questions. Does it work, and is it worth it? And so does it work is really focused on clinical outcomes.
Mm-hmm.
Is a diabetes solution improving hemoglobin A1C? Is a hypertension solution bringing down blood pressure, in a sustained and long-term manner? And we do big systematic literature reviews and dig through all the evidence to understand that. And then on the economic side, we build budget impact models to sort of help understand what a purchaser, like a health plan or an employer, is going to expect to have the impact on their spending over a 1 to 3 year time frame. So that's what we're doing. And we try to be really thoughtful about the work. We recruit clinical advisors for each report who are sort of custom selected experts in the field. We go out and interview, a dozen patients to understand their experience. And then we try to publish reports that are rigorous and clearly well researched, but they are also meant to be actionable. And that means that they are opinionated and directive, and they try to tell people what to do. And that certainly, when there's businesses on the other end of that, stimulates some feelings as you teed up. So, the good news for us has been that the credibility of the reports, I think, really speaks for itself. Mm-hmm. And so we find ourselves in discussions with people about the frame, right? We can discuss what we think is the right clinical outcome to be measuring for diabetes, but we are not arguing about what the evidence says. And so, I think that's been important to us, is let's discuss what matters, not whether we did the work well. And the companies have been so engaged. Obviously, when we first started, they didn't know us. So, knocking on their door and being like, hey, we're a new startup, limited engagement. And it has just grown and grown. So at this point, nearly every company in every report chooses to participate with us throughout our process. They don't have to. But they get on the phone, they explain their solutions to us. They tell us their why, what are you trying to accomplish? What's your differentiation in the market? And they send us tons of commercial and clinical evidence to try to inform our work, because we do want to make sure that we're really faithfully representing what those companies are doing in the market.
Yeah, that's super interesting. And to that point about being directive, I've been curious, what the impact has been of these reports, in particular, both within the companies, but also the people looking at these results. Have you been hearing from folks signing contracts that this has been really helpful in making decisions?
Yeah, so those purchasers are kind of our primary audience, because they're the vehicle by which we have impact. We don't want to put a report on a website that nobody reads. We want someone to not only read it, but then make a decision based on it. So we have a group, we call it our Purchaser Advisory Council, and they are about 50 of the leading health plans, employers, and some health systems. And it's the folks in those orgs that make these decisions. And they're the ones that give us feedback on, what's a challenge for you that we should look at? What are you going to do based on this report? And the response from them has been overwhelming. I mean, you go into employer groups and they say, where has this been? It is so helpful. And yeah, we have people saying, after the diabetes report, a lot of folks said, we knew that this stuff wasn't clinically effective. We sort of had a sense it's what we could see in our population, but diabetes is such an important issue. We didn't want to remove the solution until we sort of heard everybody else say, actually, everyone's having the same experience, and we can spend our money more wisely. So I think we've given cover to folks to make hard decisions that are really in the benefit of their membership or their employees. And then I think we've accelerated great solutions, right? I think on virtual musculoskeletal, the PT apps is a group that did very well. And I heard from folks, gosh, I didn't think any of that stuff worked. We're going to put out an RFP and see what we can bring on. So I really do think that it's become part of the decision-making ethos for those purchasers.
Yeah. Wow. Me and large employers have so much in common. We both are where has this been our whole lives? But that brings me to what came out this morning, the news report. Nye, you covered the report. What stuck out to you within it?
Yeah, so the report is on virtual tools and ways to treat opioid use disorder. And I feel like we've covered the raises of some of these companies over the past few years. And we've had chats about how virtual care can expand access. So I was kind of surprised to find from the report that these programs haven't been able to save that much money, and in some cases even drive up spending. But I'm curious what you see from your vantage point, Caroline. And so just to back it up a bit, you have looked at so many wildly different areas within health tech so far. I feel like I've covered since the beginning, diabetes tools, and also tools in mental health, AI scribes. I'm curious why you chose opioid use disorder to tackle this time, and why is it important?
We're always looking for conditions or areas of health technology where there's a high patient burden. So, big disease burden, serious impacts on society, and a lot of spending associated with it. And then where there's also a lot of innovation happening in the digital health space. And you want to find companies kind of on that steep part of their adoption curve, the ones that are growing, where your ability to indicate sort of clearly what the clinical benefits of those tools are will shape their next contract and being able to sign their next deal. And so that brought us to opioid use disorder. It is a little bit of a smaller condition than some of the past ones we've looked at. But we did a mental health report on mild to moderate anxiety and depression earlier this year. And we really wanted to also be able to look at something that was a bit more on the sort of higher severity end of the spectrum. And so this was an interesting counterpoint to that prior mental health report. And then, as you said, I think the great news here is we've got clear evidence that virtual care for OUD is effective. And I think sometimes those of us that live in the digital health space skip that step. But if you go and you talk to the on the ground providers in any field, they always say gosh, it's not obvious that what I do can translate virtually. And this is one where that really does work. And you get very, comparable clinical outcomes between sort of traditional usual care providers and these virtual tools. And that's positive. What they don't do is suddenly magically transform OUD care and achieve wildly better results, which we all hope for, but perhaps isn't surprising. And so, you see these sort of modest improvements in retention on the order of 13 more days retained over 6 months, which, every day matters if you're in recovery. But also if you're trying to, achieve a lifetime of recovery, 13 days is not good enough. We can't be satisfied with that. And then the access point, this is so tricky. The theory on telehealth has been if we remove barriers to care, right? If we make care more geographically convenient, we save people time because they don't have to go to the office all the time. We remove stigma because it's more private. That those, by taking away the barriers to care, will improve access and bring more people into treatment. But unfortunately, it's more complicated than that, right? You have to both remove those barriers, but you still have to find ways to go outside and pull new people into treatment, convince people that they want to start. And that's just what we're sort of not there yet in terms of how do you actually engage new patients?
Yeah, because the solutions they aren't able to bring in as much new patients as you would expect, I suppose. Speaking of expectations, I am curious, what have you found surprising throughout looking into this report? As if you have any assumptions that you came in with that you found was completely blown out of the water by the time you finish working on this report.
I think the access thing was the most surprising and definitely the most disappointing. And the lesson there is if you solve a barrier to care, it doesn't mean that you have solved the access problem, right? Access challenges are very multifaceted. And so, removing elements that stand in people's way is not the same as getting them to show up in the first place. And so you need both. So these are important, right? We do need virtual solutions. Everybody should have access to a provider, regardless of where they live in this country, so that when they're ready to start their treatment journey, they can. And as a field, we have to do more work to find those folks who would benefit from treatment, convince them that there are effective options available, and get them into these programs. So that was definitely surprising. The other thing I guess I'd call out is a lot of these tools focus on wraparound solutions. So they do things like offering peer support or digital CBT or something called contingency management, which is a rewards program for staying in treatment. And the idea is all of those can help people make care a little stickier, right? Keep people in recovery longer. But most of the programs kind of throw all of that at folks at once, which from an evidence point of view makes it really hard to know what really works. And so I was surprised that we didn't have more granular evidence about sort of the relative merits of, for instance, really good peer support programs, like growing out of like a traditional AA kind of model versus something like contingency management. I'd love to see more of that in the future.
Yeah. Yeah, no, I was surprised at the point too. Like, some of these companies have been around for almost a decade, and sometimes the clinical evidence is not quite there or like not peer reviewed. Yeah, but I'm curious about the cost piece too, because like you said, there's different findings for digital wraparound solutions and also like telehealth solutions that prescribe medication. And you found that for the solutions that prescribe medication, sometimes they save a bit of cost, sometimes it's like comparable to usual in-person care. But then for digital wraparound solutions, sometimes it actually drives up healthcare spending instead. So yeah, I'm curious like what led to these pretty different conclusions, and tell me a bit about how you look at the spending there.
Yeah, absolutely. So, I mean, I think if we're going to dive into the budget model here, when you look at any budget model, there's a couple of key inputs. One input is, what's the price of the product? And is the price of the digital product replacing care that someone would otherwise be getting or adding on top of that care? And that's a huge distinction. Any solution that adds cost on top of the existing care model has sort of a higher bar to reaching a positive economic impact. Whereas if you can substitute, if you can take care out, think about virtual PT. If you are letting somebody do PT at home and they're not going into a live provider, that's a substitution of cost. It just makes it easier mathematically to get to savings. And that distinction is something that you're seeing here. So the medication-focused solutions, they are prescribing buprenorphine and offering some of these support services, and then you would be getting that care instead of going to another medication-based OUD provider. The digital wraparound solutions are meant to go along with other care. So they're really layering on top. So while the clinical outcomes are sort of similar, in either case, you're trying to get medication plus some of the support services. The reality is that the digital wraparound solutions are charging separately, and the medication-focused solutions are generally priced either reimbursing through the same model or being priced at a case rate that's comparable to sort of traditional OUD care. And so it is that substitution that changes the way the model works from a pricing point of view.
Oh, that's helpful. Just to jump in here too, I gotta say it was, I think the line I like underlined and bolded and starred the most was when you said that the magnitude of their benefit is unsatisfying. Oh, I was like, wow, if I could write that way, that'd be fun. But I'd be a different type of reporter. But it's really fascinating to think about, to your point, like these solutions are set up in such a way that they could have such a big impact. To hear that it's unsatisfying is really fascinating to me. Do you think, you mentioned like wishing folks had brought different evidence bases and things like that. Do you think it's a matter of timing of, this being still early on, or do you think it's one of those things where they should have more satisfying results by this point?
That's an interesting question. So first I'll underscore, like we have one of our famous green dots next to the medication-focused solutions. So we do say these are good, these solutions are effective and they deserve to be scaled. But our role is also to sort of be that honest broker and push. And so that's what you're raising with this tension of these are important and they should be part of the treatment sort of portfolio of options. And they are unsatisfying. And anyone who grapples with OUD treatment, I think, can understand where that sentiment comes from. This is a really interesting space in digital health because I would say, most of these companies have been around a decade, but they feel more like first-gen companies than what we see in other spaces that have sort of evolved and matured more quickly. And I really attribute that to the pre-COVID policy landscape. I worked with a number of these companies, sort of before COVID, and they understood the care model that they were trying to deliver virtually, and they struggled so much to scale because of all of the sort of DEA and state licensure restrictions that made it really hard for a telehealth company to be prescribing, delivering meds, and working across state lines. And we've seen a lot of progress on some of those policies, and we get into the details in the report, but things have gotten a lot better than they were 10 years ago. But it really did sort of stall the rate at which these companies were able to progress. And, I think you see that in the maturity of both the evidence and the outcomes. So yeah, I would like to see, I'd like to see these groups go further and iterate further on their products. And I think that there'll be more positive results. And this is a really hard space. Like we don't, no in person or not, like we don't have super effective treatment modes for OUD right now. And that's the sad reality. And so that's where, from both a pharmaceutical and a care model point of view, we have to keep pushing.
Right.
Yeah. And speaking of progress, like what are the specific things you would recommend these companies to do differently moving forward? And also beyond companies, like what more can be done by different stakeholders, like payers, providers, policymakers?
Yeah. So, we do at the end of the day review evidence. So I think our first recommendation in almost all of our reports is we'd love more evidence. It enables everybody to feel more confident about both adopting these solutions, but also iterating them, right? Like these companies want to understand what's working so they can continue to put better products forward. And so I think demand for ongoing evidence is important here. It was interesting as an aside, Risetto, the pair therapeutics company that is featured, because it went through the FDA, like really dominates the literature here. And obviously that was not successful from like a business model point of view, but we do need to find ways to drive better evidence, because you see how much more information we have about an intervention like that than we do about everything else that didn't go through FDA. Beyond evidence, because I know that's a nerdy answer. I think this question on access is one that is so important for OUD treatment and really all substance treatment, but also for all of digital health, which is we're building better tools, but we don't yet know how to find the folks that would benefit the most from them and connect them with those solutions. And you hear the employer market particularly talking about this, because they at least have a captive audience with their workers, but still figuring out how to get in front of them, get in front of their family members, and get them to use the solutions that they're investing in is a big challenge. So that's like a huge, opportunity both for these companies and for the field as a whole. And then there's a ton to do on the policy side. We currently have a lot of money sitting in opioid settlement funds that is very disaggregated. And the people that manage those funds do not have great instructions or direction about sort of what the best, highest value use for them would be. And so that's a place where these virtual solutions are, investing in care via these virtual solutions might be a really interesting way to deploy some of those resources. And then I would say sort of like finalizing the progress and the proposed rules that the DEA has put forward to make buprenorphine prescribing virtually easier is really critical here as well.
It's good to hear everyone has a stake on this. But I'm curious, beyond virtual UD, what are you looking at next? What would be the next report?
The next report is going to be on GI care. So folks are very excited about that one. And that is, I think, the last one that we have announced yet. We certainly have a bunch of other things in the works. I'm also going to flag, we've been working on a big project that's not a traditional assessment, that is really focused on performance-based contracting. So across all of our work, we heard from the health plans and the employers, we want more risk-based contracting. We don't want to just pay for engagement. We want to pay for outcomes. And actually, you have increasingly, as the market matures, a lot of companies saying, sure, we are ready to put our money where our mouth is. But the contracting process for negotiating those, it's burdensome, right? And not everybody has the time to do that on a solution by solution basis and then to adjudicate those contracts. So we have brought all the stakeholders in, and we've been working with them to try to put forward effectively model contracts and standard definitions to try to make it easier for employers and health plans to be paying for these solutions in ways that are really tied to clinical outcomes.
What would that look like? Is that, I guess, maybe we should take a step back and talk about how contracting is usually done. But in my head, I don't know, there was a point where people were like, oh, it's not per member per month anymore. It's how much you're getting paid. It's something different. But anyway, what has it been and what are you hoping it shifts to?
Yeah. So I think traditionally it has been the sort of starting point has been like you pay per engaged member. So in many of these, if someone, we can take PT maybe for instance, if somebody signs up for, call it Hinge or Sword, they get the employer starts paying once that person joins, they maybe pay on a sort of per visit basis. So it's something that is sort of between fee for service or just like engaged per member per month. But increasingly across all of the clinical domains, you've got folks saying, I don't care. It's great that you engaged them, right? But did you improve their pain and functional status? Or in hypertension, did you get them into blood pressure control? And were they able to sustain it? And you have companies saying, sure, like we have those clinical results. And, if we can bring your whole population's blood pressure down, however many points or this many percentage into blood pressure control, let's create a performance-based contract around that. And you can imagine that's both valuable, but of course, like much harder to adjudicate and figure out all the data sources. And so that complexity is what we're trying to kind of streamline to the extent that we can.
I see. Hey, it requires a lot more clinical evidence, which sounds like a great thing to have. I'm excited for it. More peer-reviewed studies, please, is what I have to say.
I'm glad to have a common soul.
It's the science reporter in me. I can't shake it. We're about to be out of time, but I kind of wanted to wrap with a bigger feeling question, but we can keep it short, keep it a sentence or two. With all this in mind, with all we've talked about it today, how are you feeling about the future of health tech generally? I think there's a lot of talk about like digital health 1.0 versus 2.0, like what's brought stuff online versus what's modified things. How are you feeling?
I'm so optimistic about the future of health tech because I think that we are moving from hype to outcomes. And what you find is actually once you parse through the hype, there are great companies delivering really strong outcomes. And the more that their customers know how to recognize that allows you to like scale the adoption of really high value solutions.
Yeah, for sure. It's fun. It's gonna be interesting to watch. I feel like we're gonna see a lot shake out over the next couple of years as we see more evidence kind of make its way up. But that's all the time we have for today. Thanks so much for joining us, Caroline and I. So our health tech team will continue to cover these topics, and you can keep up with our coverage at endpoints.news or by subscribing to our newsletter. We're also hosting, this is a huge plug, first time we're doing this, a full day of health tech conversations in November 6th. It's followed by, we're having virtual sessions during the day, and then we'll have an in-person happy hour in New York that night at Book Club Bar. I'm really excited. I get to come to New York for the first time in 3 years. I'm based in Denver, if folks didn't know. We'll drop the registration link in the description and the chat. Hope to see you there. The recording of this conversation is on YouTube, and the audio will be up on Spotify. And if you haven't already signed up for our Post-Hoc newsletter, you'll get notifications when we have a new broadcast coming up. If you're not signed up, head over to endpoints.news. Then in the top right corner, hit the reader profile link, then preferences, and click to activate Post-Hoc. While you're there, you should activate health tech newsletter too. But you can also follow us on X, LinkedIn, YouTube, Spotify, Apple Podcasts, and Blue Sky by searching Endpoints News. A huge thanks to our producer, Nicole Wetzman, and our engineer, Dalen Turk. We'll see you the next time news breaks.